Hi, everybody. I just want to welcome you to the care map updates for the shared health care maps that are going to be put on the website on the 29th of November, 2022. So the vast majority of these care map updates will be obstetrical. There are a couple other ones I'm going to cover first, but most will be reviewing obstetrical care in this session here today. So the first care map that's going to be updated is A06, the EMS patient transport scope of work. So with this here, for A06, we've removed the manual repositioning for uterine inversion within our scope of work here. So when we talk about uterine inversion, this occurs when the uterine fundus collapses into the endometrial cavity, basically turns the uterus partially or completely inside out. It's a rare occasion, but it can be a life-threatening obstetrical emergency. Manual repositioning of the uterus requires placement of the hand into the vagina and pushing the fundus along the axis of the vagina towards the belly button or the umbilicus. If this is done incorrectly, or even sometimes if you do properly do this procedure, manual replacement attempts can cause severe bleeding, which may lead to an immediate laparotomy. So like it's going to cause the female patient to have a hysterectomy. So basically they're going to have to remove the uterus itself. So with this here, because it's such a high risk, high acuity procedure, we don't do it very often, and it could cause detrimental effects to our patient, whether we do it right or not. This has been removed from our scope of work at this time. In regards to ACS and STEMI, so the new update that's coming out on the 29th, it has a removal requirement to contact online medical support if you're outside the 100-minute window while transporting to the closest emergency department. So when you look at the care map here, it says, can the patient arrive at the cath lab within the next 100 minutes? It says no, and it just says initiate transport towards closest ED. It used to say contact online medical. They took that out. It was kind of discussed, and it was decided that there's enough stuff going on in the back of the truck already. You don't need to be making a phone call. Just go to closest ED and complete your T&K checklist en route. So that's that. So we're moving on to obstetrical care maps now. So the first one we're going to cover now being updated here is D09, preeclampsia and eclampsia. So preeclampsia is a progressive disorder caused by placental and maternal vascular dysfunction and resolves after birth over a period of time. So even postpartum, your female patient is still susceptible to having eclamptic episodes. So preeclampsia can occur at any time between 20 weeks gestation up to 6 weeks postpartum. So again, if you find that your patient has had her baby a week ago, she is still subject to this. So approximately 9% of cases present in the late preterm, so about 34 to 37 weeks, or in the postpartum period. So for purposes of this care map, eclampsia is based on the occurrence of new onset seizures in the absence of other causative conditions, such as like hypoglycemia, head trauma, got a history of seizures already, even if they don't have pre-existing eclampsia. So obviously we're going to use this care map if we have known or suspected preeclampsia or eclampsia. So for the purposes of this care map, preeclampsia will be assumed on the basis of one or more of the following. So the first one is severe hypertension. So if you have a systolic blood pressure of greater than 160 on 2 readings, and you can do both arms, check, cross-check, or if they have a diastolic blood pressure of greater than 110 on 2 readings. And with 25% of patients with preeclampsia, they develop severe hypertension, and one or more of the following symptoms go along with that hypertension. So with that, we're going to be looking at severe headache or visual disturbances such as photopsia. So these are when they perceive flashes of light, so you can see little spots in their vision here. And that's caused by pressure on the eye. This could also have scotomata, which is a partial loss of vision or blind spot in an otherwise normal visual field, or just straight up blindness. So with that as well, they could have severe and persistent epigastric or right upper quadrant abdominal pain. And this pain may radiate to the epigastrium or into the chest, and this pain usually begins at the nighttime. They could also be presenting with pulmonary edema, so make sure you also take the lungs with these patients. There may be excessive elevation in pulmonary vascular pressure, and this is what causes your pulmonary edema as well. So peripheral edema may be present in pregnant patients, regardless of whether they have preeclampsia. These patients may present with sudden weight gain, so greater than 5 pounds a week, so a little bit faster than normal. And they also may be presenting with facial edema, and that's more common in preeclamptic patients. So contraindications using this care map would be signs of magnesium toxicity. So magnesium doses in excess of 8 grams may result in magnesium toxicity. So loss of deep tendon reflexes is the first sign of magnesium toxicity. So we don't carry around reflex hammers with us all the time. So with that, we'd just be looking at weakening of the muscles or reduced movement. So other manifestations include slurred speech, decreased level of consciousness, decreased muscle tone. That's probably the big one we're worried about, and hypoventilation. So hyporeflexia, so absent reflex response. So basically, again, just decreased muscle tone, increased weakness, or respirations less than 12 per minute are contraindications to giving further magnesium sulfate. So the first things we want to do is maintain airway and oxygenation. Due to anatomic and physiological changes in the pregnant patient, managing the airway may ensuring adequate ventilation may be extremely difficult in near-term pregnant patients. So we always want to monitor airway and respiratory function, especially after giving midazolam and or magnesium with it as well. Midazolam in conjunction with magnesium can cause respiratory muscle weakness. So again, this is why we don't want to give it if they have that muscle weakness to start with, because it may make it worse. And hypoventilation would be a result of that. And so midazolam should be used with caution. So other things we want to do is we want to exclude hypoglycemia, any altered LC seizure call. We want to make sure we check a sugar. We get IV access when feasible. And we want to administer magnesium sulfate. So mag sulfate is the treatment of choice for the treatment of eclamptic seizures. So approximately 10% of patients with eclampsia will have repeated seizures if you just treat it as they come. So with that, if your patient seizes, we stop it with midazolam. The chance of them having a secondary seizure is very high if that's the only therapy you're given. So that's why we follow up with magnesium. So we want to consider magnesium if actively seizing or seizures persist or recur despite magnesium administration. So they are seizing, we stop the seizure with midazolam, we follow it up with magnesium to prevent further seizures. If that's not working, then we can follow up with another dose. So magnesium treatment is primarily directed at prevention of recurrent seizures rather than the actual control of the initial seizure. So again, we want to give midazolam first. Patients treated with mag sulfate have a 52 to 67% lower recurrence of convulsions and overall 58% lower risk of eclampsia. So as this correlates with medication profile M24, so magnesium sulfate dosing. And the mechanism of action of magnesium sulfate is thought to trigger cerebral vasodilation, thus reducing ischemia generated by a cerebral vasospasm during an eclamptic event. So basically, it increases perfusion to the brain. This is a slow push medication. If you give it too rapidly, it may cause magnesium toxicity and respiratory muscle weakness, which is something we definitely want to avoid. So when we come to transport, the preferred destination is an obstetrical facility where staff will have expertise and resources to manage eclampsia. So ideally, take them to a hospital that's recognized as an obstetrical facility. If the transport time is excessive, initial care may have to be provided in a non-obstetrical facility, so your closest ED. So embedded pretty much in all the care maps here are quick reference guides of obstetrical facilities in Manitoba, including Kenora Hospital, Ontario, and Yorkton Regional Health Center in Saskatchewan. So these are destinations that are designated as obstetrical hospitals. And again, this list is embedded in every obstetrical care map. So with that, if the closest hospital is within the perimeter highway, so Winnipeg's your closest option, transport to the closest of either St. Boniface or HSC and make sure you give them good heads up. In regards to going to HSC, I did talk to our medical directors on when they said HSC, do they want us to go to women's or to emerge? The response I get is at this time, it's head towards emerge because they're probably more prepared for something emergent happening with your patient versus women's may not always be ready to have something just dropped on their lap in an emergent sense. So ideally, we're going to head towards HSC merge, and then we can redirect as required or transfer them across the street after that if we need to. That's preeclampsia and eclampsia. Next we're going to go to is pre-hospital deliveries. So we're going to use this care map when we have an unplanned delivery outside the hospital. Makes sense. And it's not applicable if we're not going to be delivering a baby. So just for a review here, we're going to go over the stages of labor and when are we going to expect our baby to be born. So there's 3 stages of labor. So this chart here is called the Friedman curve, and this graph illustrates the traditionally expected rate of cervical dilation and duration of each stage of labor in a woman who has never given birth. So this is a first-time pregnancy. In the late 1950s, Dr. Friedman plotted labors on a graph and calculated the average time it took a woman to dilate each centimeter. used as a standard of rates for cervical dilation and fetal descent in most care facilities. More recent studies, though, have found that the timeline for the first stage of labor can last up to 26 hours. That's a long time. And the second stage of labor can extend up to 8 hours in patients experiencing their first pregnancy. So again, these numbers are in this graph here are calculated, but now they're finding that it actually can be longer in your first pregnancy. So the first stage of labor. So then the first stage of labor is characterized by dilation of the cervix with descent of the fetal head into the pelvis. So it is divided into a latent phase, so early labor, and an active phase, which is active labor. So the latent phase begins when the mother feels regular uterine contractions accompanied by slow cervical dilation. This is usually the longest and least intense phase of labor. So with this, the contractions are becoming more frequent, so they can be anywhere from 5 to 20 minutes apart, and they can start increasing strength. Contraction can start increasing in strength. The cervix dilates approximately 3 to 4 centimeters and effaces or starts thinning out. And some women may not actually recognize that they're in labor if their contractions are mild and regular. So again, when we get called for these patients, a lot of these times these can be the moms who are like, well, I can feel stuff. Do we need to go to the hospital? What do you think? I'm not sure if I need to go right now. When we go to the second phase, the active phase, during this phase, uterine contractions become more frequent, the cervix starts dilating more quickly, and the baby descends into the pelvis. As the mother transitions from the end of the first stage of labor to the beginning of the second stage of labor, her contractions may become more frequent and more intense. So then towards the end of the stage, the amniotic sac will rupture, so their water breaks. During transition, the mother may experience shaking, shivering, nausea, vomiting. The active phase ends when the cervix is completely dilated to 10 centimeters. So then we get to the second stage of labor, and this begins when the cervix is completely opened and ends with the delivery of the baby. The second stage is often referred to as the pushing stage. So the woman becomes actively involved by pushing the baby through the birth canal to the outside world. Imminent delivery should be considered if the patient complains of an urge to push, bear down, or have a bowel movement from the baby's head pushing against the rectum. So if your mom is in that stage 2 of labor and she says she has to go to the bathroom, you may not want to let her go because we don't want to have her baby in the toilet. Other things to look for, and of course, check with the mom, is you need to actually inspect your patient and see if the perineum is bulging or if the fetal head is actually crowning, so you can see the top of the baby's head. After the baby is delivered, the mother enters the third and final stage of labor, which is the delivery of the placenta. So this stage usually lasts just a few minutes and involves the passage of the placenta out of the uterus and through the vagina. So here's the more updated graph here, Friedman's curve. So 3 stages of labor shown as a more rapid experience for mothers that have had previous vaginal deliveries. So as noted in the graph, the latent and active phases are much shorter, which is an important consideration for us because EMS providers, we have to make transport decisions. So knowing if this is like the mother's 3rd, 4th, 5th child, the labor is probably going to go faster than their first. So that might help us make our decision if we're going to stay and deliver the child at home or if we want to load up and start heading towards the hospital. Other things to keep in mind, so just for documentation purposes as well, it's important to know how many times the patient has been pregnant before, so how many gravida, and how many times she's actually given live birth and her para. So ask about gestation length, projected due date, those are important to know as well. And ask if there's any expected complications as well, just to kind of guess ready for care, or again, decisions when it comes to transport. If there are any complications with previous pregnancies as well, if they've had prenatal care, what are we expecting? So that way we can make decisions on care. Every effort should be made to prevent birth during transport. Having a baby on the side of the highway is not always the easiest thing to do. And paramedics will not initiate transport of a patient about to deliver regardless of the transport duration. So if the baby's crowning, you're going to be delivering the baby. Don't take the mom and throw her in the truck. Birth in hospital is preferred, but it's safer on scene than during transport. So back to the care map. So as the baby reaches your mom's been pushing, so as the baby reaches the opening of the vagina, usually the head is in contact with the pubic bone. At this point, the birth canal curves upwards and the baby's head must extend back. It rotates under and around the pubic bone, as you can see in the first picture there. As the baby's head is delivered in a normal birth, it will rotate a quarter turn and be in line with the body. So support the head and neck to facilitate the delivery. Do not pull or apply pressure on the baby. So again, we're just holding, guiding. We're just stopping the baby from coming right out. We're going to allow it to come out controlled. This is a natural process. We're just there to help it along. We don't need to start pulling on babies. After the head is delivered, the top shoulder is delivered under the pubic bone, and the rest of the body is usually delivered without further problems. So once that shoulder's down and under from underneath the symphysis pubis there, you usually just catch it and the baby is delivered. So we want to exclude nuchal cords. So a nuchal cord occurs when the umbilical cord becomes wrapped around the fetal neck at 360 degrees. This occurs in about 10 to 29% of fetuses, with the chance of incidence increasing with advancing gestation age. So the longer the gestation period of the neonate, the more likely this is going to happen. So nuchal cords are more likely to cause problems when the cord is tightly wrapped around the neck, which causes effects similar to strangulation. So umbilical cord compression due to tight nuchal cords also may cause obstruction of blood flow in the thin-walled umbilical vein. So while this is happening, blood continues to be pumped out the baby through the thicker-walled umbilical arteries, causing the baby to get hypovolemia, go into acidosis, and possibly anemia, because blood's going out, but it's not coming back in. So when we look at nuchal cords, it's basically broken down into two types. So this is a picture here with a 4D ultrasound of a type A. This is a freely sliding pattern which can undo itself. So sometimes this can just self-resolve during childbirth. The cord will just loosen and come off by itself. We don't really need to do any interventions on that one. Type B is one we have to be more concerned about. So with type B, the nuchal loop that encircles the neck is in a lock pattern and it will not be able to undo itself. So we're going to have to intervene on these ones when they're born. So to manage nuchal cords, if the cord is relatively loose, slip the cord over the baby's head, as you can see in the picture here. If unsuccessful, you can try bringing the cord down over the shoulders and deliver the fetus through the cord and then unwind it after delivery. So instead of pushing over the head, we'll push it down and we'll just deliver the baby through the cord, basically. If it is a tightly wrapped cord and cannot be reduced manually, it will require clamping and cutting as a last resort. So if it is tightly wrapped cord, if it's a tightly wrapped cord and cannot be reduced manually, like we just said, it will require clamping and cutting as, like I said, as a last resort if we can't deliver the baby, or we've got legit concern for the neonate. So 2 clamps may be slipped on the cord and cut in between. This should free the neonate up for delivery and reduce that restriction on its neck. If the cord is too tight to reduce or even too tight to get a clamp on, or if the neonate is delivering too quickly for you to do these interventions, the neonate can be delivered with the nuchal cord in place. The big thing we want to do is we want to try and reduce traction on the cord so as not to rip it off the placenta or damage the cord itself. After the baby's delivered, we can clamp it, we can unwrap it, and then we can carry on with reassessing our baby. So if we need to, the next thing we want to do is suction mouth and nose. So we want to clear the baby's airway if required using a bulb syringe. If the baby is vigorous and there's minimal secretions and no signs of meconium, just wiping the face of the baby may be all that's required. So to do that, we're just going to take a cloth and gently stroke downward on the baby's nose to help expel the excess mucus and the amniotic fluid. If you are going to use a suction catheter, though, because that's what you have, don't use high pressure. So we don't want to exceed 80 to 100 millimeters mercury of negative pressure on these little ones. We don't want to hurt them. So speaking of meconium here, so meconium aspiration syndrome. So meconium itself is a dark green sterile fecal material that the babies produce in the intestines while in the womb. Meconium aspiration syndrome, or MAS, is medically defined as respiratory stress that occurs with meconium-stained amniotic fluid. So it's a medical condition that occurs when an infant breathes in a mixture of meconium and amniotic fluid. With MAS, the infant passes meconium while still in the womb. Most often this is caused by fetal hypoxic stress. In near or full-term infants, the GI tract of the neonate is mature and vagal nerve stimulation can cause reactions in the body. So under stress, such as childbirth, the rectal sphincter may relax, causing the meconium to pass into the womb or during delivery. This aspirated meconium and amniotic fluids flood the lungs at the time of delivery. So again, if they've got meconium in their amniotic fluids when they're being born, they can actually block the airways and cause oxygen deprivation. The thicker the meconium is, the more dangerous it is if it is breathed into the lungs. When the airways are partially blocked, air only reaches part of the lungs and is not efficiently exhaled back out. So basically what happens is this causes a plug in the lungs. air can go in, air can't go out. So over time, the lung may overexpand or rupture, causing lung collapse. So causes a lot of gas trapping for these little ones. So it's on the upper left there, there's a pic of newborn with the meconium staining of the skin. So as you can tell, it's got that yellowish greenish tinge. Because meconium itself is dark green. It is sterile fecal matter that babies produce in the intestine as well. It's in the womb. Normally, in a normal birth, meconium is usually passed in the first few days after birth once the newborn starts eating. It's essentially the baby's first bowel movement. It's dark, thick, and sticky. In full-term babies, however, this is not usually a severe complication. However, meconium aspiration syndrome, it occurs if a premature baby, it's almost a sign of it's pretty much going to be a guaranteed sign of a prenatal infection. So we're always concerned about that. It is quite uncommon to see meconium-stained amniotic fluid prior to 34 weeks just because of GI motility. So you'll see the picture of the lungs there on a radiograph. So it's a radiograph of a term newborn with meconium aspiration syndrome. So this radiograph shows diffuse hyperinflation in patchy areas of mixed emphysema and atelectasis. I can never say that word right. And a partial collapse of the lung. So if you look at the lung sizes there, the moderate sized left tension pneumothorax, so there's an air block phenomenon. This is commonly seen secondary to the requirement for pressure ventilation in a child with significant large small area obstruction caused by meconium plugs. So basically what's happened is that they've had to increase the force of their ventilations on the baby because the meconium is basically plugging their lungs, their airways. So in order to get past that, they've had to squeeze the bag harder and harder. So by squeezing the bag harder and harder to get around those plugs, it causes more air to go in the lungs, great, but that gas doesn't come back out, so it causes gas trapping, and that's how we can cause a pneumothorax, turning it into a tension pneumothorax. So this is definitely a thing to be aware of. So once we suction the mouth and nose and make sure there's no meconium aspiration, we're going to help deliver the baby's torso. So after the head is delivered, shoulders should rotate to help deliver the body. Do not pull on the baby's head or the body itself. Again, we don't need to force this. It's a natural process. We're just there to help. We let the baby and labor contractions do the work, but be prepared as the body may come out very quickly after the head is being delivered. So gently guide the baby out, ensure to give support of the head and neck. So we want to make sure that we're supporting that baby and make sure that they arrive safely. So talks about clamping and cutting the umbilical cord. So for vigorous newborns, current evidence suggests that cord clamping should be delayed for 30 to 60 seconds, and that's a recommendation that's in the care map now. If the infant is not vigorous or requires immediate assistance, such as like with their nuchal cord, like we talked about earlier, they're not breathing, they've got limp muscle tone, the priority is on the priority would be on resuscitation of the newborn, and the cord must be clamped immediately. So a lot of studies have shown that delaying cutting the umbilical cord is associated with greater hemoglobin concentration for the neonate and better iron storage between 3 to 6 months of life and lower incidence of transfusion and neonatal hypotension compared to immediate umbilical cord clamping. So it's better for the babies. So it's one less thing to worry about immediately when the baby's born. We can do our assessment. We don't have to immediately clamp the cord when the baby's born. When it comes to actually clamping the cord, just when I was researching for this presentation here, I read a lot of different documents, and it seems like no one can really agree how far away from the abdomen you should clamp the cord and cut it. Depending which book you read, which research study, people all have recommendations. So the measurements range from 3 inches to 6 inches from the neonate's abdomen, and then wherever you pick 3 inches to 6 inches, everybody agreed on 2 inches past that, you should put your second clamp and then cut in between. One I read that was really good recommendation for EMS. It's just, they said if you go like 4 finger widths from the abdomen, so it's the abdomen, 4 fingers, cut the cord there. That's a quick way to measure it as well. Another thing that might help determine how far you clamp the cord and cut it is that if you believe the neonate will need resuscitative measures once at a facility or some kind of fluid transfer, things like that, you want to leave a longer length of umbilical cord so it'll be easier to facilitate cannulation of the umbilical cord. So if you're thinking your babies might need a transfusion or some kind of resuscitation, once you get to the facility, maybe leaving more of the umbilical cord available to the staff there would make it easier for cannulation of the umbilical cord. So after you've clamped and cut the umbilical cord, we're going to help deliver the placenta. So again, natural process. We're just there to help facilitate and make sure things go well. So placental separation can involve a slow progressive detachment from the uterine wall, and it's brought about by the physical changes which occur during and after the actual birth of the baby. So during the second stage of labor, as the baby gradually leaves the uterus, the force of contractions reduces the size of the uterus to create more efficient contractions. So this causes less surface area in the uterus, reducing the placental attachment site, resulting in placenta becoming thicker and smaller in diameter itself, which causes increasing separation from the uterine wall. So as you can see in the diagram there, you got a larger, more space in the uterus. So as it starts contracting, getting smaller, it basically starts forcing the placenta off itself because it just doesn't have that contact with the uterine wall anymore. The effectiveness of the placenta detaching depends on the extent to which the placenta site is reduced. If contractions are firm and forceful, the placenta may be expelled immediately after the baby is born. If they're less effective, such as like the mom's tired, because like 26 hours of labor, it's a lot, they may be less effective and placenta separation may be delayed. So once the baby's born, check the placenta after the placenta is delivered then. Check the placenta to ensure no part of the placenta or membranes have remained inside the uterus. So if any part of the placenta or membranes have been retained in the uterus, it can cause postpartum hemorrhage and infection for mom. So we always want to check both sides of the placenta. A healthy placenta should look shiny, gray, and translucent so you can see the color of the underlying placental tissue. Just one thing, I don't have a picture of it here, but when I was researching this, they did have pictures of pregnant patients that were positive for COVID while pregnant, and it actually caused, I want to say deformity, but it was very much a discoloration of the placenta. So if you do find that your mom did have a history of COVID and her placenta is very discolored, that is not an abnormal finding for COVID positive pregnant patients. So for this picture here, this is displaying the membrane sac that the baby developed in. So this is attached to the placenta. And we want to check both sides. So when we look at before here, so this is the baby side, so with the umbilical cord attached there. And then we want to check the side that was attached to mom. So the mother side of the placenta should be a dark maroon in color. Sometimes the placenta may have calcified areas that feel gritty to the touch. May also have areas that are white or gray in color, indicating there has been tissue death in that area of the placenta. Noting this can help with possible ongoing care for the baby. So it's definitely something you want to report to the receiving facility. So here we have a couple of different types of placentas. So for these ones here, this is a twin-to-twin placenta known as a monocryonic placenta. So with this, it means that you've got twins that have been sharing a placenta. There may be discrepancies between placental territory, resulting in one fetus having decreased development out of the other. So when you have patients like this, as you can see in the pictures, they may not share the placenta equally. So this is when you can have one twin's bigger than the other, and you may only have one placenta delivered for both babies. So if the birth goes well, everything's great, one baby comes out, two baby comes out, the placenta will be delivered as normal. It just, you'll just have one placenta for both babies. And then here's some abnormal looking placentas, because as you can tell here, compared to the ones we were looking at that were healthy, these ones are very discolored, misshapen. So these are definitely things of concern that should be reported to the receiving facility. So the next one we're going to talk about is administering oxytocin. So as per medication profile M16, oxytocin all postpartum patients pre-hospitally. So in the hospitals, they don't automatically give every patient that delivered oxytocin, but we're going to do that pre-hospitally just because it's a more diverse environment. So we want to try and get a good control of bleeding earlier. So oxytocin is used to control hemorrhage in postpartum period as it increases the intracellular calcium, which will then cause the muscle to contract harder with increased frequency and duration. This causes uterine contractions to squeeze those uterine vessels, and this ideally will slow the postpartum hemorrhage. So as it puts more pressure on those vessels, they'll get constricted, and that should stop ongoing hemorrhage from the mom. You don't want to give oxytocin if there are multiple gestations due to the increase of contraction cause increased strength in contractions, resulting in decrease of placental blood flow. And this can cause fetal hypoxia and abnormal fetal heart rate. So again, as we strengthen those contractions with oxytocin, as I was saying before, that's going to help pull the placenta off the wall. So if we have another baby that's still in utero, we don't want that because then that will start starving out the baby and could cause hypoxia. So in patients with multiple gestations, this could also cause uterine rupture. If labor is progressing normally prior to medication administration, just let it go. We don't want to give oxytocin until all the babies are delivered. So once the baby's born, we're going to assess them. We're going to assess the newborn for size and we're going to use the APGAR score to determine quality of breathing and muscle tone. So it's the APGAR score here. I'm sure everybody's familiar with it at this point, but basically what we're looking at is we're going to do a score every 5 minutes. So a score of 7 to 10 is considered reassuring. A score of 4 to 6 is moderately abnormal, and a score of 0 to 3 is deemed to be low in full-term and late preterm infants. So at 5 minutes, when a neonate has a score of less than 7, neonatal resuscitation program guidelines recommend continue recording at 5-minute intervals up to 20 minutes. So when you do your first score at 5 minutes, if they score very low, we're going to do extended reassessments just to keep an eye on our babies. So we might have to do the APGAR score up to 4 times. So if the answer is no, they're not a term gestation, they don't have good tone, they're not breathing or crying, we're going to go to newborn care and resuscitation, which we'll talk about later. If the answer is yes, everything seems to be doing good. If the baby presents with minimal issues, place with the mother for skin-to-skin contact so they can stay warm. You may also suggest breastfeeding of the infant to promote natural oxytocin release to reduce postpartum hemorrhage. And if this is not done already, now we can look at, do we need to suction the airways? So always ensure to keep the infant warm during this process. We want to make sure they don't get cold. And then it's another benefit of giving them to mom. So we always want to keep doing continuous ongoing assessments as required, along with ongoing APGAR scores if we think they're needed. So as we move on here, it says, is there labored breathing or persistent cyanosis? If baby has ongoing cyanosis, especially centrally, or ineffective breathing, we're going to go straight to resus. Now the question is that everything's good? Can we get to the scheduled delivery site within 30 minutes? So if they have a scheduled hospital they were supposed to have their baby at, can we get to that site within 30 minutes? If the answer is yes, we go there. If the answer is no, can we get to any obstetrical facility within 30 minutes that's listed on this list here of obstetrical facilities? If the answer is no, we're going to go to the closest ED. If the answer is yes, we're going to go to that facility. And that's pre-hospital delivery. So the next thing we're going to cover here is umbilical cord prolapse. So we're going to access this care map if there's no unsuspected umbilical cord prolapse during delivery. Makes sense. That's what the care map's all about. So there's no contraindications to this, because obviously if we're not dealing with it, we don't need to access this care map. So umbilical cord prolapse is an uncommon obstetric emergency that can have significant neonatal morbidity or mortality. It commonly accompanies incomplete breech presentations. We'll talk more about that in a little bit. And is diagnosed by seeing or palpating the prolapse cord outside or within the vagina, in addition to abnormal fetal heart rate patterns. So we don't have monitors for that, but something to keep in mind, it will affect our heart. Identified risk factors for umbilical cord prolapse is if the maternal age is greater than 35, it's a preterm labor with low birth weight. If the mom's had multiple previous babies, if they're having multiple babies now, such as twins or triplets, if there's excessive accumulation of amniotic fluid, and then again, that's something that hopefully they diagnose the prenatal care, which is why I want to ask about that. And if there's a premature rupture of the membranes, so they broke their water early. So umbilical cord prolapse is a surgical emergency that cannot be treated in the pre-hospital setting. These babies need assisted delivery either by C-section or instrumental assist delivery. So fetal survival in this condition is measured in minutes and depends on immediate delivery. It can be obvious where prompt recognition, immediate action can be life-saving. Ideally, the baby should be delivered within 30 minutes of diagnosis to optimize perinatal outcome. So with that, we recognize that the cord's sticking out. We want to get this baby to the hospital as soon as possible, and ideally obstetrical facility. So we're going to urge the mother not to push, as this can cause worsening of the cord compression. So again, if there's weight on the cord, when they bear down, it's going to put more pressure on the cord, which is going to cause hypoxia for the baby. When transporting, secure in the left lateral position, otherwise keep face down, hips up. So for here, we have the picture here of, it's called the steep Trendelenburg. And this is just to relieve pressure on the umbilical cord. So to achieve this position, have the mother roll on her side and tilt toward her abdomen. So we're going to elevate the top leg and support with pillows or a blanket while leaving the bottom leg straight. And so this is also known as an exaggerated Sims position. So with this here, as you can see, we're elevating up the leg there. So hopefully that'll keep pressure off the umbilical cord. The other one here, it has the face down, hips up. So this is the steep Trendelenburg or knee chest position, really pressure on the umbilical cord. So the issue with this one is that it will take the pressure off the cord, but the problem is we can't secure patients appropriately to the stretcher in the ambulance. So for transport, this may not be the one you want to go with. So we want to then hold presenting part off the pelvic brim. So manual elevation of the presenting part off the pelvic brim to prevent cord compression can extend that window for intervention, improving the neurologically intact fetal survival. So with that, again, we want to make sure there's no pressure on the cord because that's going to restrict oxygen, causing hypoxia, causing brain damage. It's all bad. So we want to keep pressure off of that cord, and we want to make sure we're not the ones compressing the cord ourselves. So we want to make sure that we're not putting our hands on the cord or unnecessarily touching the cord. And we do not compress it, for like I said, that causes problems, and we don't reinsert it back into mom. We are, however, going to cover the umbilical cord with moist sterile dressings. And we want to make sure we take caution not to excessively manipulate the cord when we are putting dressings on it, as this can result in artery vasospasm. And obviously that's going to impede blood flow and harm the baby. And we want to try and keep the cord warm as well. So if we're using cool moist dressings on top of the umbilical cord, we want to try and keep the cord warm as well because we don't want to damage it and make it cold. And then, of course, with this as well, there's always that concern. So we're going to prepare for neonatal resuscitation because if the baby's still coming, we might have to resuscitate the baby at this point. And we're going to transport. Ideally, we're going to want to transport, like I said, to an obstetrical facility where staff have expertise and resource to manage cord prolapse, and they have experience resuscitating neonatal patients. Here's a list again. Like I said, they're embedded in all the care maps. So if you have the option to go to one of these hospitals, go there. If the closest hospitals within the city, again, we're either going to St. Boniface Emerge or Health Science Center Emerge. And that's umbilical cord prolapse. So the next one we're going to cover is shoulder dystocia. So indications for this is known or suspected shoulder dystocia during delivery. It's a complication that occurs during delivery when an infant's shoulder becomes lodged in the mother's pelvis, as you can see in the pictures on the slide here. Shoulder dystocia is a clinical diagnosis that should be suspected when any of the following occurs. So when the fetal body fails to deliver within 60 seconds of the head delivering, normally it's a pretty quick process. Once the head's out, the shoulders follow. But that's not happening, or it doesn't seem like it's progressing normally. The fetal head is delivered during a contraction and then retracts back in. And with a push, the head goes out and goes back in. It's called turtle sign. That could be an indicator of shoulder dystocia as well. And the usual gentle downward traction. So again, just gently directing the baby on the shoulders of the fetal head, failed to get the baby out. It helps to facilitate the delivery of the shoulders. And contraindications, there's no contraindications using this. So urge the mother not to push until the anterior shoulder is released. So delivery will not complete until the anterior shoulder is released from behind the pubic symphysis. So pushing by the mother, excessive traction on the fetus, or fundal pressure, so pushing at the top of the uterus, may worsen dystocia by wedging the shoulder against the maternal pelvis. This can also cause baby shoulder to impact on the pubic bone during contractions, stretching and damaging the brachial plexus nerves. So we want to be careful not to cause more damage to the baby. So we could attempt to deliver unseen. A stable environment will definitely make it a lot easier to deal with this. You could already, if not done already, consider requesting ALS and contacting online medical support. So with this one as well, so if the baby's been in distress for a while, has been kind of stuck in the labor cycle for a bit, we're going to be getting ready for neonatal resuscitation. If the shoulder dystocia takes 5 or more minutes to resolve, the neonate is likely to be depressed and need vigorous resuscitation. So get your gear ready. So for this, to get the shoulder out, we could use what's called a Roberts maneuver. This is embedded in the care map here as well for how to do the procedure. I'd also strongly recommend calling online medical support if you're going to do any type of procedure. That make sure they can guide you over the phone and ensure you're doing this procedure properly. This maneuver is best done with 2 or more providers. So to perform this maneuver, you're going to elevate the legs in the McRoberts position. So you're going to lay the mom as supine as possible, as comfortable for her, and we're going to do a sharp hip flexion. So as you can see in the picture here, we're going to position the patient with the hips completely flexed, so knee to chest position, and this may free the anterior fetal shoulder. So care providers may need to assist mother in holding this position. If she's been in labor for quite a long time, she might be too tired to hold her legs up, so she might need our support. She probably will need our support. So by doing this, this improves pushing efficiency and will often relieve shoulder dystocia by rotating the maternal symphysis up over the fetal shoulder and flattening the sacrum. So again, as you can see there, it tilts the pelvis in a different direction. So that way, hopefully it loosens up the shoulder and baby can come out. So next step for this, though, if that doesn't work, we're going to apply suprapubic pressure with the palm of your hand while directing the anterior shoulder down and laterally. So this ideally will bring the shoulders of the baby into a different plane or different angle, which is towards the widest diameter of the pelvis. So we want to avoid fundal pressure. So we're just going to push on the symphysis pubis. We're not going to push on the fundus, which is the top part of the uterus, as that will force the anterior shoulder further into the pubic symphysis. So you can see in the picture here, that's really not what we're going for. So then we're going to provide gentle inline traction of the fetal head. So again, we want to be very careful because excessive traction will force the shoulder against the symphysis and can cause further fetal injury. After release of the shoulder, normal guidance should allow for delivery of the neonate. So now the big question is, did that work? If the answer is yes, do your regular stuff and go to the hospital. If the answer is no, we're going to look at transporting. The big thing is, though, with paramedics with advanced care ACP practice scope, if they have had appropriate training, they're feeling competent would be a better way to put it. If you're competent, and maybe you may be able to deliver the posterior arm or shoulder with a delegation from and direct supervision by online medical physician. So you'd have to make a phone call to do this. So in the care map here, it has Appendix A, and again, this is just for ACPs. We're going to do delivery of the posterior arm. So to do this, you place one hand in the vagina along the posterior arm of the infant. You're going to grasp the forearm or the elbow, and we're going to make sure that arm is flexed up across the chest. And then we're going to sweep the arm up the fetal chest, ensuring not to sweep along the back. So we're basically going to take the shoulder and move it over. This should hopefully deliver the posterior arm in the shoulder, and this should allow the anterior shoulder to slip out from underneath the maternal symphysis pubis. If you're unable to reach the arm because it may be above the pelvic brim, so we just can't get our hand there, it may be possible to deliver the posterior shoulder by auxiliary traction, which brings us to the next appendix. And again, this is for ACP scope only. So auxiliary traction for delivery of the posterior shoulder. Again, you need to call online medical if this is the direction you want to go to as an ACP. So to do this, step one, you have another provider gently flex the fetal head towards the anterior shoulder. So as you can see in the picture here, and then we're going to grasp that posterior shoulder. Then we're going to overlap the middle fingers of each hand in the posterior fetal axilla. So as you can see there, so basically you're getting your circle, your first finger and thumb around the axilla, and your second finger placed on top of the arm. So we're going to keep arm firmly against the chest and apply traction through the axilla only. So we're just going to put pressure in the armpit. We're not going to pull on the arm. We're not going to pull on their neck, nothing like that, just on that armpit. So next step would be to pull the posterior shoulder downward along the curved maternal sacrum, then out. So you can see here, we're going to go along the bottom of the hips there, and we're going to try and get that shoulder out, and then hopefully the posterior arm can then be delivered. And again, that's only with making a phone call to online medical first. So if that worked, if it didn't work, we're still going to look at transporting. We have to go somewhere. And again, transport to one of the hospitals on the list that's on the care map, ideally, because they have the specialists that can take care of this, or at least assist with it. And if not, go to your closest ED. But if you're close to St. Winnipeg, we want to go to St. B or HSC with these patients. And that's shoulder dystocia. So next thing we're going to get into is incomplete breech presentation. So a breech presentation is defined as a fetus in a longitude lie with the buttocks or feet closest to the cervix. So the percentage of breech deliveries decreases with the advanced gestational age. So 22 to 25%, so like basically a quarter of births prior to 28 weeks gestation can appear breech. 7 to 15% of births at 32 weeks gestation and 3 to 4% at term will present as breech. So as the further the mom gets along in her pregnancy with the longer gestation time, the less likely we are to see breech. Incomplete breech presentation is a surgical emergency that cannot be treated in the pre-hospital setting. Fetal survival is measured in minutes and depends on immediate delivery for this baby. So indications for this care map, obviously incomplete breech presentation during delivery. It's not fully understood why babies present as breech, and it can happen at any time during the pregnancy. But there are certain risk factors that are considered, such as patients' prior pregnancies, if they've had more than one baby beforehand, if they're having twins, that's a big one, or more at one time. It could be too much or too little amniotic, too much or too little amniotic fluid. And again, this might be recognized already with prenatal care. There might be actual problems with the uterus itself. They may have placenta previa, where the placenta covers the opening of the uterus, so it's just different positioning of everything inside the mom, or just it's an early birth. So usually they will use ultrasound to confirm a breech presentation. And there's no contraindications to use this care map. Obviously, it's very specific. So a breech presentation occurs in approximately 3% of all deliveries, about 1 in 4 incomplete, either footling with extension of the hips, knees. So with this one here, with the footling here, so we have a complete footling presentation and incomplete footling presentation. So with the footling presentation, there may be one or both, but the big one is with just the incomplete footling presentation. That's when you might just have one foot sticking out of the vagina when the baby's being delivered. So here's an ultrasound. So I was saying they can diagnose this previous to the birth. So you have the ultrasound of footling breech, sorry. The foot is pointing towards the cervix. As you can see, the cervix right there, and there's a foot directed right towards it. A second type of incomplete breech is with kneeling, with the extension of the hips and flexion of the knees. So basically the baby's kneeling when it goes to come out. So we're going to urge the mother not to push with this, because ongoing pushing can greatly increase the risk of birth injury, increase risk of the baby to get stuck in the birth canal, and possibly increase pressure on umbilical cord, cutting off oxygen supply to the baby. So when transporting, like we talked about before, we're going to secure in the left lateral position to take pressure off the presenting part. We don't want to stimulate the infant because we don't want to start stimulating their breathing or anything before they're delivered. And we always want to be ready for resuscitation. So if umbilical cord prolapse is present, we're going to treat it like we did with the previous care map there. We're going to take caution to not excessively manipulate the cord, as like we said, that can cause vasospasm and it can do more harm to the neonate. So, and we're going to keep the cord moist with sterile dressing and keep them warm as well. And like we talked about in the previous care map, so manual elevation of the presenting part off the pelvic brim to prevent cord compression can extend the window for intervention and improve the chances of a neurologically intact baby. So yeah. And we're going to go. So the transport destination is obviously an obstetrical facility. That's the idea. However, as time is a big factor, we're just going to go to the closest hospital and make sure you give them lots of heads up. And that's incomplete breech presentation. So then we're going to go in frank or complete breech presentations. We went partial, now we're going complete. So breech presentation occurs in approximately 3% of all deliveries. It describes the fetus where a presenting part is the buttocks or the feet first. So this is one of those full footlings. So with frank breech here, so both hips are flexed and both knees are extended so that the feet are adjacent to the head. So as you can see in the ultrasound here, baby's got their feet right by their face. And this accounts for 50 to 70% of breech fetuses at term. So for a complete breech, both hips and both knees are flexed. And this accounts for 5 to 10% of breech fetuses at term. And most can be delivered vaginally, as once the larger torso and thighs pass through the birth canal, the relatively smaller head and shoulders should follow. So indications for use of this care map is complete breech presentation during delivery. Makes sense? And if you're not having that, you don't need to access this care map. So for these patients in the hospital, C-section deliveries are preferred by clinicians over vaginal delivery. So depending on how far in their stages of labor, we may want to consider, if the mom knows that their baby's breech, we may want to consider the closest obstetrical hospital. And if we should be going there, we should be delivering on scene based on where they are in those stages of labor. So we're going to ask the parents, are you expecting any breech? Are there any complications such as a breech delivery? We're going to ask these questions before the baby actually delivers. So again, that'll help with our transport and care decisions. If transporting does not seem like a good idea, so it's not really a viable option, attempt to deliver on scene and be ready to call for a second truck or intercept, and make sure you call online medical for help with direction as well. So with this, we're going to prepare for neonatal resuscitation. Because babies delivered through breech birth are more likely to have birth asphyxia than those who had a regular vaginal birth. So this can be caused by head entrapment, compression of the umbilical cord, because again, if the bump's coming out first, it's going to have pressure on that cord, cutting out blood flow to the brain. and rapid decompression of the head and other birth trauma. So there's things that can happen here, so be ready for the worst. So with this here, though, we're going to support the fetal torso. So as you see here, we got the baby coming up bum first. We're basically just going to support. And if the mom is pushing and everything's going great, we can just assist with the delivery. So we're going to support the fetal torso. And as the baby's coming out, we're going to look, are the toes pointing up or are they pointing down? If they're pointing up, we're going to grasp the fetal ankles and lift the body skywards. And just keep allowing the mother to push. Do not force on the baby by pulling. So like I said, don't be yanking babies out. You're going to support the shoulders once they present by placing your hand on the scapulas and along the neck of the neonate. So again, as you can see in the picture here, we're going to support that head and neck as it comes out. Be prepared for issues such as shoulder dystocia or the neonate's head becoming trapped in the pelvis, which is another emergency in itself. So we're going to secure the baby's head once delivered and check the umbilical cord for any tearing. Because again, if the cord comes out first, it might have a lot of pressure and it's possible that it tears either at the cord or off the placenta. So then are the toes pointing up? If they're not, they're pointing down. We're going to gently guide fetus horizontally and apply suprapubic pressure. So with this, we're going to encourage maternal pushing to push out the neonate's fetal buttocks. As they're being delivered, so like I said, we're just going to support them. We don't want to pull or put pressure on delivering parts. Early extrication of the buttocks increase the risk of head entrapment, especially in a partially dilated cervix. So again, we're not going to force it. We're just going to let it happen naturally. We're just going to assist the process. And also if we force it, we can increase the risk of nuchal arm entrapment. So like the picture I had earlier where the baby had the cord wrapped around its body, we're putting them at higher risk for that by forcing the baby to come out by putting pressure on them. Once the buttocks have been delivered and visualization of the umbilical cord, the legs will likely have delivered themselves by this time if the fetus is in complete breech position. So you can see the legs come out, we have the umbilical cord, and we want to maintain support of the neonate's body, but again, do not pull or put necessary pressure on the baby or the umbilical cord. We're going to proceed with active delivery of the shoulders and arms as the scapula and the arms emerge out of the mom. So a big thing we want to keep in mind is we never apply pressure to the fetal abdomen. So we're just going to grab around the chest, the shoulders, but never actually grab the soft tissues of the belly. Because we put pressure on the abdomen, the adrenal glands, the kidney, the liver, and the spleen, that we could cause injury to them with excessive pressure during the delivery process. So we want to make sure we're not causing any organ trauma to these babies while we're just assisting them coming into the world. So as we carry on here, as the baby comes out, so the torso is out, so the fetal chin will lay in the posterior aspect of the vagina and or lower uterine segment. So as you see in the picture there, it's lower down in the pelvis as well. So encouraging pushing the head may just help it deliver spontaneously, which would be great. And we always want to make sure we support that head and neck. Once the baby's delivered, we're going to lift the newborn upward to deliver the head in a controlled manner. So take extreme caution when you do this to avoid hyperextending the fetal back and the fetal neck. So don't just grab them and yank them like we used to teach them, flip them. We just want to make sure we support them. We don't need to like immediately flip them. We just want to make sure we support the baby as they come out, supporting the head and neck to prevent any further trauma. And again, we don't want to get their head and start lifting them with their head still trapped, because then we can extend their neck and back and cause injuries there as well. So moving on here, so we want to know, did the head actually deliver? If the answer is yes, we can go to newborn care and resuscitation, because again, this baby might be in distress because of the head entrapment, things like that. So once we get the head out, we want to make sure we do a full assessment and a possible resus. If the head has not delivered, we're going to support the fetal torso and perform the V maneuver. So with this here, we're going to place our hand into the vagina between the vaginal wall and the fetal face. So we're going to cup our hand over the nose and mouth to prevent obstruction, because the baby might actually be breathing through the mouth and nose at this point, just through stimulus. The umbilical cord may not be as effective, so we want to make sure that it's not compressing its face against the vaginal wall. And of course, you should probably get going at this point. Things are getting serious. If you're not able to deliver on scene, the preferred destination is always one of the obstetrical facilities that's listed in the care map. If not, we can just go straight to the closest ED and make sure you give them a lot of heads up. And that's, Frank, our complete breech presentation. So we talked about a bit already about going to this care map, so newborn care and resuscitation. So indications for use of this care map is a preterm newborn, so less than 36 weeks. Baby born with poor muscle tone, not crying or breathing upon delivery. Sorry. The baby has labored breathing or persistent cyanosis. Peripheral cyanosis post-delivery isn't an abnormal finding. That could be normal. It should self-resolve. But if they have central cyanosis, that's probably not going to self-resolve, so we're going to need to help these babies out. And if they have bradycardia, so that means they have a heart rate less than 100 for newborns. So contraindications, so newborn no with certainty to be less than 20 weeks gestational age. So newborn no with certainty to be less than 20 weeks is universally regarded as incapable of survival outside the womb, and delivery before 20 weeks is termed a miscarriage. It may be challenging to differentiate a premature liveborn with absent vital signs from a stillborn fetus because they're probably going to be very small. Especially with late stillbirth, it may be just as challenging to distinguish late fetal death from a viable neonate without signs of life. Unless it can be confirmed that the gestation age is less than 20 weeks, so the mom doesn't know how long she was pregnant for. She may say she wasn't even aware she was pregnant. Or intrauterine death has already occurred. Paramedics must consider all neonates viable and initiate resuscitative efforts. So Appendix A, this is a reference document as well, but this is actually in the care map now, the Newborn Care and Resuscitation Care Map. So it has more information about miscarriage, stillbirth, and perinatal death. So also at any time you can call online medical for assistance with this. So that's in there now. So in neonatal resuscitation, every set of actions should be completed in 30 seconds. So every round of ventilations or CPR should be performed for 30 seconds, and the newborn reassessed every 30 seconds. So as you can tell on the care map here, you've got your little stopwatches there for 30 seconds. What should be done in that time? So by 30 seconds, the airway should be open and the infant stimulated to breathe if required. By 60 seconds, or the first minute of life, the breathing and heart rate should be assessed and ventilation initiated if required. And by 90 seconds, breathing and heart rate should be reassessed and CPR initiated if required. So the first thing we're going to do here in the first 30 seconds is after the baby's been delivered, we're going to position and open the airway. So we want to place the head in the neutral or sniffing position using a shoulder roll if required. So we're going to avoid excessive neck flexion or extension, so we don't want to tilt the head too far one way or the other. And even if IGLN is in place, placement of the head in this position is still required because that just sits at the opening of the trachea. We want to make sure that head's in the neutral position so that we can ventilate appropriately. So we're going to clear secretions. So again, we can look at suctioning. So you always suction the mouth first, then the nose with the bulb syringe. And like stated earlier, if you are going to use powered suction, do not exceed 80 to 100 millimeters of mercury negative pressure. So we're going to dry and keep warm. So one thing to keep in mind when we're drying them off is infants less than 32 weeks, you want to gently dry them because their skin could be very fragile. We don't want to cause injuries. And considering covering the torso and limbs with plastic wrap. So we have that picture of the baby there. It looks like they're basically in a BVM bag. Placing them in plastic will help preserve moisture and warmth. Plastic wrap in itself can be considered an effective and safe additional intervention to prevent hypothermia in preterm infants. If the mother and baby are not requiring intervention, please use skin-to-skin contact to maintain warmth. So that's going to help out mom and help out baby. And we could also stimulate the baby. So actions of suctioning and drying the baby may all there's stimulation that is required, along with flicking of the soles of the feet. That's maybe all you need to do to stimulate that baby. So after that 30 seconds there, we're going to check to see if there's apnea, gasping, or heart rate below 100. So we're going to check effectiveness, suppression, and presence of breathing. So, are they breathing? Are they breathing adequately? We're going to check the heart rate either using the femoral, brachial, or umbilical cord for a pulse. But studies have shown that there may be difficulty for care providers to accurately palpate and determine heart rate in newborns. Auscultation was actually shown to be more accurate. So if you have a stethoscope available, the umbilical cord provides greater accuracy than palpating the umbilical cord. If you can auscultate, palpate the umbilical cord. So to palpate the umbilical cord, palpation of the base of the cord is most accurate. So if you're not sure about finding brachial arteries, femoral arteries in your little ones, just check at the cord. But ideally, auscultation works the best. And you can auscultate the chest and listen to lung sounds while you're there as well. So if the heart rate is below 100, we're going to ventilate with room air. We don't want to use additional oxygenation with initial ventilations. Hyperoxia is harmful for the lungs as oxygen toxicity may damage the pulmonary epithelium and activate the surfactant within the lungs. That helps our lungs stop from sticking together, helps them inflate, deflate without them just closing and staying that way. As well as the lungs may form edema and interstitial thickening in the lungs. It's also been shown to increase risk for severe retinopathy. So it's also been shown to cause blood disorders and brain damage with long-term deficits by using too much oxygen. So normally when someone's not breathing, we're going to put on the O2, 12 to 15 liters per minute. For these babies, because we don't want to cause the hyperoxia, we're just going to ventilate through room air initially. So next thing it talks about there is Mr. SOPA if necessary. So these are just ways to troubleshoot if you're having trouble ventilating your baby. So the first thing there is M, we have mask adjustment. So attempt to rescue your hand technique, one forming a seal, one ventilating. This works really well because a lot of times as paramedics, when we try to get a good seal on a mask, we tend to push down. So as we want the head to stay in that neutral position, pushing down to get the airway, that can block off the airway. So if we have one person straight up holding the mask up while the other person ventilates, again, just little breaths, that's all we need. It can help maintain that airway and help us get better breaths there. For the R, we have reposition the head. So like I said, make sure that head is in that neutral position. So one person on the mask, one person pinching that bag, giving little puffs of air, and make sure that head is in that good neutral position to get good air entry. Second step, we have suction and open airways. So we have MRS, suction. So suction mouth and nose, make sure you've got all the secretions out of there, and then open the airways. So again, ensure that the head's in the right position. Step 3, pressure increase. So we could increase ventilation pressure, so we could be squeezing the bag a little bit harder. We can consider increasing our PEEP or including the pop-off valve. But the big thing is we want to be very careful about barotrauma because, again, if we start squeezing too hard, we can actually pop their lungs, as simple as that. So we want to make sure that if we close off that pop-off valve, that's there to stop barotrauma from happening. If we just want that extra pressure to open up the lungs, we have to be very careful with that. And again, it doesn't take a lot of air to ventilate a neonate, just little pinches of air. You don't need to crush in the bag with every squeeze. You can look at using an alternative airway for A. So you can look at using your size 1 eye gel if you're still unable to effectively ventilate the neonate without an airway in place. So a size 1 still may be too big for some neonates. So again, good positioning, good ventilation, that's probably your best bet for these little ones. So it talks about putting oximetry and put them on the monitor. So place pulse oximeter and neonate and put them on the monitor. Ideally, your pulse ox should be on their right hand, but again, as it shows in the pictures here, you can put it on their feet. As per the care map, it recommends putting it on the right hand. And if you're going to put them on the Zoll to monitor them, make sure you set your Zoll to pediatric setting because they'll have different alarm limits for you based on their age. We don't have neonate settings on our Zolls, so just put on pediatric. That's the best we've got right now. So for this here, this is in the care map here. So it is your SpO2 during initial minutes after birth. Again, on the right hand. So what this idea is that because we're saying like everything's done in 30 seconds, we redo our APGARs every 5, reassessing our patient. This is to show that circulatory response is going to take a little bit of time for a baby to switch from being in utero to the real world. So what we want to look at is that if you're assessing your baby at 5 minutes and their SATs are 80%, that's fine. We don't need to start hyperoxygenating our babies even more. Even if you're able to get your SAT on early, you get it on in like 3 minutes. If their SATing is 74, that's a normal SAT. That's why this is in here. Because as the baby transitions from never using their lungs before and most of the circulatory system, now they're transitioning to outside world, that adjustment is going to take time. So we want to make sure that if we're seeing low SATs, that goes in accordance to how many minutes they've been alive for or in the world for. So we always want to make sure we're checking that because, again, at 10 minutes, if they got a SATs of 70s, that's concerning. But at 3 minutes, if they have SATs of 70s, that's normal progression. So we just want to keep that in mind when we're checking our SAT levels. So now we want, excuse me, now we want to see if there's apnea, gasping, or a heart rate below 100. So again, we're going to reassess the neonate's pulse. So is our heart rate below 100? If the answer is yes, is the heart rate below 60? That's concerning. If the heart rate is below 60, we're going to start CPR until we get the heart rate back up over 60. So when we do CPR for neonates with the low heart rates or the bradycardic, we're going to do CPR at a ratio of 3 compressions to 1 breath. So it'll be 1, 2, 3, puff, 1, 2, 3, puff, 1, 2, 3, puff. We're going to ventilate now with supplemental oxygen because obviously things are not working well for us just on room air. And we're going to set it at a rate of 10 liters per minute with a reservoir bag in place. And of course, we're going to reassess every 30 seconds. Does their heart rate still remain below 60? If it does, we can consider volume expansion. So the baby may actually be in hypovolemic shock due to fetal and maternal hemorrhage, placental umbilical trauma, if the umbilical cord itself was damaged during delivery and there was blood loss, or even extensive vaginal bleeding during delivery can cause hypovolemia in your patient as well, in the baby as well. If they're not responding to chest compressions and positive pressure ventilation, we can consider establishing an IO and administering normal saline at 10 mLs per kg over 5 to 10 minutes. If that doesn't work, we can look at a second bolus after that. The big thing we want to be cautious about with IO is because they may be very small depending on how far along in the how many weeks pregnant the mom was. We want to be careful. Our IO needles might still be really big, so we may not want to drill it all the way to the hub because we don't want to go right through their tibia. Also, for landmarking for using an IO, usually go with the tibial tuberosity, but the problem is as the babies are little, they may not have a very easy to palpate tibial tuberosity. So with that, what we might want to do is you just find the top of the tibia and make sure you go down. That way we're not drilling in anywhere near the growth plate because obviously we want to resuscitate our baby, but we don't want to cause bone development issues down the road. So just make sure you stay away from the head of the tibia and stay away from that growth plate. And if that's where you're going with this, with giving volume expansion, we're going to be making phone calls to the physicians for direction on that. So let's say that everything was going okay though, or baby didn't have apnea, gasping, or heart rate below 100. We're going to look at is their labor, breathing, or persistent cyanosis. If the answer is no, we're going to give the baby to mom. It's her baby. And that's going to help keep the baby warm. So we're going to cover them up and we're going to just continue to monitor and reassess the baby on a regular basis and take them to the hospital. If there is labor breathing or persistent cyanosis, we're going to make sure airway's open. We're going to check our ECG. We're going to put them on the pulse ox. We could look at giving supplemental O2 and then just keep ongoing evaluations. So with this, when we give O2, we could look at giving free-flowing supplemental, a blow-by O2 at 5 liters per minute. And this is just holding the tube open at the end of the by the baby's mouth and nose and making sure we're not blowing it up into their eyes. We just want to like blow it across, but not up into their face. We don't want to get lots of oxygen in the newborn's eyes. If ventilation keeps heart rate above 60 but less than 100, we're going to continue to ventilate. When we're doing that, now we can start looking at giving O2 at a flow rate of 5 liters per minute without a reservoir bag. In the hospital, they use oxygen blenders where they make a concentration of room air and medical oxygen. That way, again, we're not hyperoxygenating these babies. So with that, this will deliver about 30 to 35% oxygen if we take that reservoir bag off. So we're flowing 100% O2 into the BVM, but because we don't have that reservoir bag, it's going to blend it with the room air and give them a lower percentage of pure oxygen. And that's it. It's quite the care map. So last one here is postpartum hemorrhage. So we've looked after baby. Now we also need to look after mom. So with postpartum hemorrhage, it's most commonly due to poor uterine tone, which usually responds well to oxytocin administration and fundal massage. Other causes of postpartum hemorrhage include placental retention, trauma to the actual genital tract, so tearing, things like that, trauma to the rectum, uterine rupture in itself, and uterine inversion. So indications for this is obviously significant bleeding after delivery of the placenta. So there will be some blood loss during delivery. That's not abnormal. So usually it's less than 500 mLs though. So if there's excessive ongoing bleeding even after the placenta is delivered, that's not really normal. Or again, it's coming from somewhere else. So postpartum hemorrhage should be suspected when bleeding is estimated to be greater than 500 mLs, or signs and symptoms of hypovolemia are present for your mom after delivery as well. And obviously, if we're not worried about bleeding, we don't need to access this care map. So first step in this care map is exclude uterine inversion. Do not administer oxytocin if inversion is present. So like I said, uterine inversion is a rare but life-threatening obstetrical emergency, and exsanguinating hemorrhage can occur. This could be caused by excessive cord traction and fundal pressure. Clinically, it will present as bloody mass of filling or protruding from the vagina. So as you can see in the pictures here, it's not the prettiest thing ever. So basically their organs have turned inside out. So if you do come across this, oxytocin and fundal massage are completely contraindicated. This will just cause worsening hemorrhage and bad times for the mom. This is obviously going to be very uncomfortable for mom, so pain control should be a consideration. And this is a true emergency. One of their organs is outside their body, so we need to look at immediate transport. So if that's not an issue with uterine inversion, if there's visible injuries such as tearing from the delivery, we can have our maternity pads and we apply direct pressure, or we can use ab pads and apply direct pressure and try to control bleeding at the site itself. We could also, we're giving the baby to mom, so it's going to keep the baby warm. We can encourage breastfeeding because that will naturally help produce oxytocin as well, which again will cause those contractions, which helps constrict the blood vessels in the uterus, will control bleeding. So it's a win-win for mom and for baby. So you can perform a uterine fundal massage. So this is in the care map itself. So a fundal massage will stimulate the uterus to contract. So like I was saying, it'll help compress those blood vessels. Massage should be maintained while vascular access is being obtained and oxytocin given. So again, oxytocin can be with IV or IM. So if you can't get an IV, you can always give that first dose of oxytocin IM. We're going to continue massaging the fundus until the uterus is firm and bleeding stops. So how do we do this? So to properly massage the fundus, so one hand is cupped to massage and gently compress the fundus, the top of the uterus, towards the lower uterine segment. So the other hand remains cupped against the uterus at the level of the symphysis pubis to support the uterus. This will be not a comfortable procedure for the mom. It's not going to feel very good. Fundal massage is there to help encourage the uterus to contract. After the placenta is detached and delivered, the area where it was attached to the uterine wall, naturally it's going to bleed. So uterine contractions, again, naturally help to push out that blood and help put pressure on the blood vessels in the uterus in order to stop the bleeding. So that's why we want to do this massage. So after that, we're going to, if we haven't got IV yet, we can give oxytocin IM. If we do have IV, we can give oxytocin IV. So again, and that's going to be as per M16 oxytocin admit. So every mom outside the hospital is going to get 10 units of oxytocin, either IM or IV. If you have multiple babies being born, do not administer oxytocin until all the babies are delivered. So as per M16 as well, it says here, initiate oxytocin infusion if bleeding persists. So for this, we're going to mix 40 units of oxytocin in 1 liter of normal saline and run at 250 mLs an hour and administer with a pump. So to do this properly, you're going to drop your 40 units of oxytocin. You're going to inject it in the saline bag. You're going to tilt it back and forth, mix it up, hook it up to the line, and we're going to hook it up to a pump. If you don't have a pump, we're going to ensure a drip rate of 250 mLs an hour by using a macro drip set adjusted to 42 drips per minute. So they already did the math for you, so that's kind of nice. So you just have to count the drops, make sure you set the right rate, and you're good to go. So a new addition to the postpartum hemorrhage care map is consider TXA. So as per medication profile M28, TXA, we're going to have 1 gram over 10 minutes. Again, in the care map for a medication profile for TXA, it talks about trauma or hemorrhage. So I would say that childbirth is traumatic hemorrhage. So we can give TXA. Again, TXA would be something to be done en route because we're going to want to transport. Again, preferably to an obstetrical hospital in that list of embedded that's embedded in the care maps of different options you have for facilities. And if you're in the cities, you can go to St. Boniface or Health Science Center. That's all I got. Thank you very much. Feel free to contact me if you have any questions.